In our last discussion, as you can see, we ended with the normal physiological absorption of fats from our diet. And we also discussed about the relevant pathological diseases which we can have leading to fat malabsorption. Okay, we saw that there are three phases of this fat absorption, or basically any absorption for that matter, which is the mucosal phase, or rather, let me start from the beginning: the luminal phase, the mucosal phase, and the post mucosal phase. We saw the defects associated with each. Then, in the post mucosal phase, I said that chylomicrons are being formed, right, from fatty acids, because fatty acids themselves cannot be transported via the lymphatics. Just like they could not be absorbed as such, we needed micelle formation for absorption. Just like that, we need chylomicrons for their transportation via the intestinal lymphatic channels. Associated with this is the postmucosal part of the fat absorption. Associated with this, we have two very, very important disorders. One is the defect in this esterification, that is the defect in chylomicron formation, which is called Abetalipoproteinemia. And the second is the transport via intestinal lymphatic channels, this being obstructed or there being a problem with this. This is called intestinal lymphangiectasia. So in this module, we'll be discussing about these two topics. Hopefully this will be a shorter module, and from the next video onwards, we'll be discussing about the other nutrients or other carbohydrates and proteins which are left as far as their absorption and the diseases concerned with their malabsorption is concerned. We'll talk about that in another video. So this video will be about Abetalipoproteinemia and intestinal lymphangiectasia. So let's start with Abetalipoproteinemia. A mouthful, I know, to say, but very, very important. Abetalipoproteinemia. So what exactly is this? I've already given you an introduction as to what this is. Basically, what is happening is the fatty acids, they form chylomicrons with glycerol, and for this we need ApoB48 cofactor. This is called esterification. Due to some gene defect, which we'll see as to what gene defect it is, this ApoB48, there is a deficiency of that. So chylomicrons are not being formed. This is called Abetalipoproteinemia. So Abetalipoproteinemia, let's get on with the salient points about that. First and foremost, this is also called neuroacanthocytosis. This is a very, very interesting name, and you should remember this name. Why? Because as we talk about the clinical symptoms and some investigations of Abetalipoproteinemia, you will understand why this name is important. Okay? So what exactly is the etiopathogenesis for this? The etiopathogenesis. What's happening? I've already explained to you what there is. But basically, this is an autosomal recessive defect. Okay? And there is a defect in the MTTP gene. What is this MTTP gene? Microsomal triglyceride transporter protein. So since there's a defect in this gene, what happens is this leads to a defect in what I was talking about, ApoB48. And since there is a defect in ApoB48, there will be defective chylomicron formation or no chylomicrons being formed, and so this will lead to malabsorption. Okay, this is it. Done. Now let's talk about the much more important thing, which is what are the clinical symptoms? What exactly will the patient present to me with? Clinical presentation. See, this is where the name comes into play. Neuroacanthocytosis. So this is something to do with neuro. Actually, to be more precise, this is actually a triad. Triad of what? Triad of three systems together. First is that there is a neurological problem here. What neurological problem do we have here? This is mostly something called ataxia. We'll study about ataxia later in CNS, but basically ataxia means disbalance, uncoordinated dysregulation of balance. Okay, and this is basically happening because of vitamin E deficiency. What does vitamin E have to do with this disease that we are talking about? We'll talk about that in a little bit. Don't worry. So the first manifestations are neurological. Secondly, what we have is we have eye manifestations in the eye, or better to say retinitis pigmentosa, leading to night blindness. Okay, this is another manifestation that we have. And third is, since we are studying this in the GI tract, the GI chapter, so basically GI manifestation. What GI manifestation do we have? Of course we know this, malabsorption of fat. So this will lead to what? Steatorrhea. We know this already. So these are the three triads of the clinical presentation of Abetalipoproteinemia. Now, so this is the clinical purview that you need for diagnosing this, but obviously this is a radiological, or rather this needs investigations for diagnosis, for confirmation. And this is where the second half of the name is actually going to come into play. Acanthocytosis. So it has something to do with acanthocytes. Basically what we have is that, let's quickly write it, investigations. So basically what is happening is, in the peripheral smear of blood, obviously, we will find something called acanthocytes, special type of cells. Okay, special type of cells called acanthocytes. This is why basically why it is called neuroacanthocytosis. Done. Now, is this diagnostic? No. In fact, this is just to make up for the name. That's why I told you. This is an important point that you should remember, obviously. But this is not what we are using in common clinical practice to diagnose. We are not taking peripheral smear of a patient with Abetalipoproteinemia and looking for acanthocytes. Although that is there, but we have a much more important, much more sure shot way of knowing that this is in fact Abetalipoproteinemia, and that is very, very important: postprandial endoscopic biopsy. Endoscopic biopsy. Very, very, very important. See, since we will be talking about different GI disorders, we'll find that endoscopic biopsy will come into play in many of the diseases. But Abetalipoproteinemia, very, very, very important. Remember this. Abetalipoproteinemia is one of those very rare entities wherein, first of all, we are taking a postprandial endoscopic biopsy. Majorly, we take preprandial, before eating, we do an endoscopic biopsy. This is one where we do a postprandial endoscopic biopsy, first of all. And second of all, very, very important, it is 100% diagnostic. Such an incredible thing. 100% diagnostic in postprandial endoscopic biopsy. So, this brings us to a neat little thing that I want to pass you on as far as information is concerned, which is there are a few conditions wherein 100% endoscopic biopsy diagnosis. There are a few conditions in the entire GI chapter wherein endoscopic biopsy is 100% diagnostic. You don't need anything else for diagnosis. First is the one that we just now studied, Abetalipoproteinemia, quite the mouthful. Second is related to this, A gamma globulinemia. A gamma globulinemia. And third is a disease that we'll study in a later video, which is Whipple's disease. I think I already mentioned Whipple's disease when we were talking about global malabsorption. Don't worry, we'll do a video on global malabsorption. Whipple's, A gamma globulinemia, and Abetalipoproteinemia. These are the three diseases which are 100% endoscopically biopsy diagnostic. Okay, you don't need anything else. So what exactly are we seeing in Abetalipoproteinemia? In the postprandial endoscopic biopsy, we are seeing duodenal, we are doing a duodenal biopsy, and we are seeing vacuolation. Mostly vacuolation. Vacuolation in what? Vacuolation in the enterocytes. Okay, vacuolation in the enterocytes. So that brings us to another thing that I forgot to actually mention, or I did mention actually, but I said that I'll explain it later, which is, why are we getting ataxia? What is this vitamin E deficiency? Suddenly, why am I getting vitamin E deficiency as a clinical presentation in Abetalipoproteinemia? So you should know what fat soluble and water soluble vitamins are, right? So let's quickly jot down what the fat soluble vitamins are. The fat soluble vitamins are A, D, E, K. We know this. So these vitamins need fat for being soluble, for being absorbed. Do you now see why vitamin E deficiency we get with Abetalipoproteinemia, which is leading to fat malabsorption? My body is at a loss. My body is not being able to absorb fats, which is why we are studying this under fat malabsorption. Hence, vitamin E, which is a fat soluble vitamin, has problems in being absorbed, and hence vitamin E deficiency is seen, leading to neurological manifestations. But this is not the only reason, because if this was the only reason, then why am I specifically seeing vitamin E deficiency only? Why am I not seeing vitamin A, vitamin D, or vitamin K deficiency? Actually, we do see that, because I haven't talked about this in detail, but you will later learn, or we will learn this together. I don't want to play higher teacher over here, but we'll learn this together, that basically malabsorption, diarrhea, these things have a way of presentation other than, not diarrhea, but malabsorption. It has a way of presentation which is not just reflected by steatorrhea, or not just reflected by osmotic diarrhea. You can also see this in the manifestations of the deficiencies it causes. So for example, a global malabsorption will lead to deficiency of all the nutrients. So I'll get a lot of, nutritional deficiencies, like vitamin B deficiency defects will be there. So I'll get chelosis, I'll get red beefy tongue, I'll get angular stomatitis, I'll get vitamin A deficiency, night blindness, I'll get vitamin K deficiency, so easy bruisability, petechiae, bruises, ecchymosis, all those things. I'll get vitamin C deficiency, I'll get perifollicular hemorrhages, all those things I can get. I'll get osteopenia, I'll get osteoporotic bones, easily fracturable bones. We'll see that these are actually very, very helpful symptoms as far as diagnosing something like celiac disease is in a later module. But I'm just giving you a taste of that. So don't ever think that why am I specifically targeting vitamin E? Am I not getting vitamin A deficiency here, vitamin D deficiency here? I can get that. I am getting symptoms of that. But it is not characteristic for Abetalipoproteinemia, which is why I did not mention it. What is characteristic? Neurological manifestations, gastrointestinal manifestations, and retinitis pigmentosa in eye. Now, this gastrointestinal manifestation is steatorrhea, and within this, you will get other nutritional deficiencies as well. It is clubbed within that. But my question is, why is this vitamin E deficiency so much more marked in this? The reason for this is not just because vitamin E is a fat soluble vitamin, of course, that is there, but there is another reason. That is, basically, due to my Abetalipoproteinemia, another interesting thing that happens is A beta lipo also leads to something called decreased VLDL formation. Decreased VLDL formation from liver. So this will lead to, VLDL is actually needed for vitamin E transportation, so this will lead to actually decreased vitamin E secretion by liver. Okay, and also since chylomicron formation is gone, so due to decreased chylomicrons, obviously vitamin E absorption, that will also go down. So these are the reasons why I'm getting a marked vitamin E deficiency over here, and that may lead to neurological manifestations, especially ataxia. Done. So this brings us more or less to the end of Abetalipoproteinemia. This is all that we needed to know. Now let's move on to the next disease that we had, which was intestinal Lymphangiectasia, IL. I'll just write it like this. So what exactly is happening? Chylomicrons, we know this. The chylomicrons, after being formed, they were actually transported across the intestinal lymphatics into the blood, because that is what lymphatics do. They'll drain into blood at some point, but to transport the chylomicrons first from the GI tract up to some blood vessel, we need the intestinal lymphatics, right? That is why intestinal lymphatics are very, very, very important. Okay, this is the physiology. Now, what is the problem over here? See, intestinal lymphangiectasia basically means that there is some problem with the intestinal lymphatics. What exactly is the problem? The problem can be something secondary or something primary. Primary is what we are more interested in, but let's see what the secondary thing is. What does secondary intestinal lymphangiectasia mean? Meaning that there is some kind of a secondary cause for my lymphatic channels getting obstructed or getting hampered, the lymph flow getting hampered. Some secondary cause. It's not related to the vessel itself. It's not related to some birth defect or something like that. Some secondary cause. What can be the secondary cause? Very, very important. First of all, lymph node obstruction. So wherever you get lymphadenitis, wherever you get lymph node getting enlarged, whatever conditions it might be, it will lead to increased lymphatic pressure and exudation. Increased lymphatic pressure leading to exudation. So the lymph will spill out from the lymphatics into the GI tract itself. Okay. Where exactly do you get lymph node obstruction? Tell me. Very, very easy. I'll get it in lymphomas, and I will also get it in something called Crohn's disease. We'll see what Crohn's disease is later. Okay, Crohn's and ulcerative colitis, they are examples of, or rather they are the only two diseases which we'll study under the massive heading called inflammatory bowel disease, IBD. Very, very interesting. Crohn's disease and lymphoma, they'll lead to enlarged lymph nodes, and these lymph nodes will lead to obstruction of the lymphatic channels, which were tasked with basically transporting the chylomicrons into the blood peripheral circulation. That won't happen anymore. Lymphatic pressure will keep rising because of this obstruction, and there will be lymph exudation. Okay. What is the primary thing? Primary, we don't have an actual cause for this, but due to some defect, there is abnormally dilated lymphatic channel, which means that there is increased pressure, and thus there will be exudation in lumen, intestinal lumen. Understood? So here the cause is not secondarily due to some tumor, not secondarily due to some stone, not secondarily due to some lymph node. No. By birth, or not by birth, but due to some genetic defect, the intestinal lymphatics within these persons who suffer from primary intestinal lymphangiectasia, it is already abnormally dilated. It has a lot of pressure. So what will happen is, due to high pressure, lymph will exudate and it will move into the GI tract. So this is a very, very interesting example of something we call protein losing enteropathy. Very, very, very important. And this brings us to what we call to be the clinical presentation. Protein losing enteropathy. So we are losing proteins. Where are we losing proteins? How are we losing proteins? Basically what is happening is, if this is your GI tract, you have these lymph channels over here. But these lymph channels, normally it should be like this, but now it has become like this big. So the lymph which is filled in this is under high pressure, and what that will do is it will start leaking into the GI tract. So we'll start losing lymph, and along with that, whatever was being carried in those lymph. So we will also lose proteins and fats into the GI tract. Okay. This is a very interesting thing because we have other examples as well where we lose proteins from our body, right? What are some other examples where we are basically we have a protein losing component? For example, very, very common nephrotic syndrome. Nephrotic syndrome. Okay, we have liver cirrhosis. These are very, very important examples of protein losing diseases. But there is a very, very interesting difference between these things and the protein losing enteropathy that we find in primary intestinal lymphangiectasia, which is the condition that we are studying right now. What is the difference? The difference is the protein losing enteropathy in primary intestinal lymphangiectasia. In this, when we are losing proteins, we are losing both albumin and globulin. Very, very important. So this is hypoalbuminemia along with hypoglobulinemia. Okay, but when we are losing proteins in nephrotic syndrome or liver cirrhosis, mainly we get hypoalbumin but increased globulin. Hypoalbumin with increased globulin, or we can also get decreased globulin in conditions like multiple myeloma, okay, which is a hematological malignancy. We'll talk about it later. So in multiple myeloma, what's going on? There is a defective monoclonal production of a single linear strain of antibodies, right? So only IgG light chains are being converted. We'll see to that later. So basically what's going on is only one class of immunoglobulins, that is which are globulins, they will start to predominate and all the others will be stopped producing. So overall the globulins will start going down and there is a reversal of AG ratio. Well, again, I'm just getting this out. We'll see to all this later. You don't have to understand it right now. But the important difference between all these things are, whenever albumin decreases, globulin goes up, and vice versa. Globulin decreases, albumin goes up. There is something like this. But both albumin and globulin going down together, the most important reason is primary intestinal lymphangiectasia. Why? Because we are losing proteins. See, nephrotic syndrome, we are losing protein in urine. Liver cirrhosis, protein synthesis is decreased. Multiple myeloma, there is defective synthesis. Defective synthesis of protein. But primary intestinal lymphangiectasia, what's going on is we are losing proteins in the GI tree. Because like I mentioned from over here, this is what is going on. So what will be the clinical symptoms over here? Very simple. When you lose protein, what happens? Edema. When you lose protein, what happens? Ascites. And since it's coming to the GI tract, what will happen? Diarrhea, osmotic diarrhea. Why are you getting edema? Why are you getting ascites due to losing proteins? This is why all these conditions will have edema, ascites and all this. Cirrhosis, liver cirrhosis also we get this, nephrotic syndrome also we get this. Why? Because you're losing proteins. So what's going on actually? Since you're losing a very osmotically active substance from your body, what's going on is there is hyperdilution. So from the cells actually you are losing proteins. So cells are becoming more diluted now compared to the interstitial spaces. And so what's going to happen is from cells, water will move out into the interstitial spaces, into the third space and get accumulated, leading to edema, leading to, when it's in the peritoneal cavity, ascites. Okay, that's what's happening more or less. We'll study this later in hepatology. So these are the clinical symptoms of intestinal lymphangiectasia. And if it is secondary intestinal lymphangiectasia, then we will also get lymphoma, you'll get some kind of other Crohn's disease and the symptoms of Crohn's disease and all that. But if it is primary, then this is what you will get. Now, investigation, obviously, I cannot clinically correlate and say that this is intestinal lymphangiectasia. I may have a some degree of suspicion, but majorly I need some investigations. What are the investigations that I need? The investigations, again, a very specific thing that you need to remember. For example, a very specific thing that you needed to remember in the last condition, Abetalipoproteinemia, was that acanthocytes, where was it? Yes, you find acanthocytes in the peripheral smear. This was something very specific to Abetalipoproteinemia. Just like that, in this condition, you find fecal alpha-1 antitrypsin. The fecal alpha-1 antitrypsin is elevated in intestinal lymphangiectasia. This is a very specific test for this condition. Other than that, obviously, you will do endoscopy. And in endoscopy, in the CT scan, what will you find? You'll find wall thickening. Okay, wall thickening of what? Of small intestine. Small intestine walls will be thickened, and you will find diffuse white lesions. You might find, you will find the dilated lymphatic channels, basically thickening of the wall. Okay, all these PG topics you don't need to understand. And other than that, another viable thing is video capsule endoscopy. Another way of endoscopy, a capsule with a camera fitted, small capsule with a camera fitted, ingested, goes in, records all of that, and we retrieve the data. We can see that on a camera, on like a monitor outside. This is video capsule endoscopy. Okay, so this brings us to the end of basically everything that there is to know as far as fat malabsorption is concerned. There is a lot to uncover here. Basically, you need to understand the fat physiology. You need to understand how lipids are physiologically absorbed, how they are digested, how they are absorbed, the different phases of the absorption, and the different defects that are associated with these phases. Malabsorption syndromes, of the luminal syndrome, of the luminal phase of absorption, of the mucosal phase, of the post-mucosal phase. Okay, in the luminal phase, you had defect in either the pancreatic lipase due to chronic pancreatitis, or all the defects related to the bile acid synthesis. Bile acids. Basically, if bile acids may be synthesized less in liver cirrhosis, bile acids may not be transported well, like in primary biliary cholangitis or primary sclerosing cholangitis. Let me just quickly give you an overview. Bile acids may be transported there, but they immediately encounter deconjugating bacteria like in SIBO, small intestinal bacterial overgrowth, or the bile acids which were supposed to be retransported by reabsorption due to intrahepatic circulation from the terminal ileum due to some disease in the terminal ileum like TB, like Crohn's. It is not. So intrahepatic circulation is gone and all of this is gone. Okay, this was basically the luminal phase. Then we came into mucosal phase, and we saw that mucosal phase basically only global malabsorption things which can destroy the integrity of the small intestinal mucosa. These things can affect the mucosal phase of fat absorption, and basically the mucosal phase of every kind of absorption, proteins or carbohydrates as well. This is why these diseases, they are called global malabsorption syndromes. Celiac disease, Whipple's, tropical sprue. Then we came to the post-mucosal phase, which is basically after the fatty acids, they were incorporated within the enterocytes. they again need to form chylomicrons with a reaction called esterification, in which ApoB48, glycerol, these things are needed. Chylomicrons are formed, chylomicrons are loaded into the intestinal lymphatics. Intestinal lymphatic channels actually drain into the blood vessels, inferior vena cava. And from there, they reach the heart, and then from there they are transported. So if there is a problem with the esterification reaction, ApoB48 defect, due to defect in the MTTP gene, we call this the Abetalipoproteinemia, and this is also called neuroacanthocytosis, because there is a neurological manifestation over here with ataxia due to vitamin E deficiency, and acanthocytosis, which is basically acanthocytes which you are seeing in the peripheral smear. This is the defect in the MTTP gene, defect in ApoB48, defective chylomicrons, and then malabsorption. What are you seeing in this? There is a triad here, neurological manifestations with ataxia due to vitamin E deficiency. Then you have eye manifestations with retinitis pigmentosa, and we have GI manifestations, basically steatorrhea. Then we saw that the investigations peripheral smear and postprandial endoscopic biopsy is 100% diagnostic. What are other conditions in which they are diagnostic 100%? Abetalipoproteinemia, A-gamma globulinemia, and Whipple's disease. Okay. Then we saw that why the vitamin E deficiency is so marked in this. First of all, because it's fat soluble. Second of all, because chylomicrons are not being formed here, so there is no one to transport the vitamin E. And third is because VLDL secretion is also gone, so nobody to transport vitamin E from the liver as well. Then we came to another entity, intestinal lymphangiectasia, which is basically what is happening here. Intestinal lymphatic channels, they are for some reason, primary or secondary, obstructed, and hence what's happening is lymph from these channels are being there is exudate of this lymph into the exudation of this lymph into the intestinal lumen itself. It can be due to a secondary cause like some stone, like some lymph node obstruction itself, as we see in lymphoma, as we see in Crohn's disease, or it can be a primary cause, which is basically abnormally dilated lymphatic channels. What will happen over here is, this is protein losing enteropathy. Nephrotic syndrome, liver cirrhosis are other conditions where we are also losing proteins, but there we lose selectively albumin, not globulin. So globulin goes high, but here we are losing both albumin and globulin. Okay, and this is leading to edema, ascites, diarrhea. Investigation, fecal alpha-1 antitrypsin is specifically elevated. If you do, you can do an endoscopic biopsy, that also will show you, but basically a CT scan will also show you. That is wall thickening, there is diffuse white lesions, and lymphangiectasia on endoscopy. And video capsule endoscopy is also viable over here. Basically, another thing that I forgot to mention is the treatment. How do you treat this? Basically, primary intestinal lymphangiectasia, there is not much to treat, or there isn't much to do here over here, other than put the patient on something called medium chain triglyceride diet. Basically, whatever I just, all the fatty acids and all this that I just discussed with you, this is all long chain fatty acids that we talked about. Okay, long chain fatty acids are the fatty acids that are present in our diet. But interestingly enough, what we have seen is short chain and medium chain fatty acids, they're not much present in our diet. Medium chain fatty acids are present very low in our diet, almost nil, and short chain fatty acids are never present in our diet. Okay, so all these symptoms that you get are basically due to long chain fatty acids. So that is why we are putting the patient on medium chain fatty acids. Okay, short chain fatty acids we don't get from food. They're not at all present in food. Okay. We find short chain fatty acids in our colon due to fermentation of the undigested carbohydrates by the colonic bacteria. Short chain fatty acids are formed. Don't need to know that right now. Okay. So this brings us to the end of our discussion of fat absorption, fat malabsorption, and all that is related to it. In the next video, we'll talk about carbohydrate absorption and protein absorption, and along with that, malabsorption syndromes. Thank you very much.